Good afternoon and welcome back here at ECCMID TV, brought to you live from Pavilion 1 here at the ECCMID Congress Center in Lisbon, Portugal. I'm very happy to introduce my next guest to you, who is all the way here from Switzerland and has taken place in our TV studio here. Dr. Angela Huttner, welcome. You are from the University Hospital in Geneva in Switzerland, and you are also known for being the associate editor of the CMI journal. And I believe this ECCMID, you've had a number of tasks and roles to fulfill, one of which was chairing the late-breaking research from the CMI. Would you like to share a little bit about that session with us? Because maybe not all our viewers had managed to attend.
Thank you very much. Yes, I chaired the session with Andre Khalil, a fellow editor, and it was really quite a pleasure because it was good for us as editors to go back and look at what we had been doing in the last, let's say, 6 months. It was a session of Latebreaker manuscripts that, so the definition there is that we selected manuscripts that have been accepted by CMI, but that are not yet in print. So they're really hot off the presses.
And high quality, because they already have been accepted.
Yes, indeed. They were very COVID heavy.
Yeah.
We only had time for 5 studies to sort of showcase these 5 studies, and I think out of the 5, 4 were COVID related, and this just reflects our reality. We still receive a ton of COVID manuscripts from all over the world now. When it first started, of course, we got a lot of manuscripts from China, and then we started, with this. As the first wave was moving along, we started to get manuscripts from Italy and then from the US. And so since then, it's been COVID manuscripts from all over the world.
Yeah. So was it the Latebreaker session? Was it like an oral presentation session? Was there a lot of discussion, interaction with audience as well?
Yeah, that was the other thing that was really nice. It was oral presentations. So these 5 articles, we invited the authors to come and present their work. And they had enough time, which was nice. They had 20 minutes each, or even a bit more. And it was really nice for us as editors to get to see these authors, because you exchange, you have contact with them, through the system, through emails, but you never get to see the 3 dimensions and really interact in real time with them.
So were there also questions coming from the audience or from other people that were there present that really made you, scratch your heads as editors, thinking like, why didn't we think of this, or did we miss something?
Yeah.
Does that happen?
There were, indeed, there were. And there were a couple of questions/comments from the audience, which were really nice, and that's where you see the importance of in-person conferences. People were sort of generating new ideas while listening to these presentations. Future directions. Did you try doing this in this new population? Could you think about doing this? Which was really nice.
And do such questions have to lead to like adaptation of the manuscripts that are
Too
already
late.
Too late.
Too late.
Definitely
Those are
late-breaking.
accepted, and what's nice about the journal, about CMI, about most medical journals, is that, you put it out there, you've published it, you can't really change it, you can't change the study's been done, but the dialogue continues. People can write a letter, there can be commentaries written afterwards. So it's still a living thing, even though the study's been done, the manuscript's been written, but the ideas are still, there, and we can still talk about
dynamic.
them.
So would you care to share like one of the topics that was discussed or presented at the late-breaking session that particularly caught your eye or your interest?
Yeah, there was one study that was done on an inhaled corticosteroid for COVID to try to prevent it before the disease became too severe, right? So those are already sort of inherently difficult studies to do because you're preventing something. It's hard to count up something that you've
It was someone
prevented.
who had already been infected with SARS-CoV-2.
Yeah. It was a study where patients were infected. It was early days. It was it was only in the first few days of symptoms. The idea was you gave them this inhaled steroid, not oral, but inhaled, and you see later, okay, do they progress to hospitalization, need for oxygen, or death?
Were they patients at risk for severe COVID?
They were indeed. They were. The population was selected on purpose to find people at risk of progressing, because indeed this is the problem. You need a very high sample size to find the few events that there will be. So what happened with this study, and I think it's really good that we accepted it and that we spotlighted it. What happened with the study was new information became available from a totally unrelated study that an inhaled steroid wasn't really working so well in a different study. And then this study, which was run in many centers in France, underwent an interim analysis. And they saw that it wasn't, even with the small numbers that they had recruited, it wasn't doing much. So the Data Safety Monitoring Board of the study decided, it's not really fair to ask patients to participate when we don't think there will ever be any real effect of this inhaled.
Tough decision.
Yeah. And so, I mean, it's a study that was very well designed, but it was what we call a negative study. And a lot of journals, most journals and most human beings, we really gravitate towards positive results, right? We want drama, we want obvious differences, and it's
but then
not.
We get publication biases.
Yes, exactly. And we, with our editor-in-chief, Leonard Leibovici, we wrote an editorial recently about how we want to publish abandoned trials. We want to publish negative results because in the long term, these actually really help with clinical practice, perhaps more than these flashy positive studies. So,
So it's really stimulating that you also selected this study to be a Latebreaker here on ECCMID.
I mean,
it's a good example for all researchers out there with negative studies.
I mean, people do so much work to do a randomized trial, and if I recall, this study didn't have a whole lot of funding. I mean, this was really a labor of love of many academic, just junior researchers, just trying to create knowledge and share knowledge, just their own hard work. So it should be put out there. It should be shared. It's very useful knowledge. What does work is great, but also what doesn't work is very important knowledge that has to be put out there. So,
well, it's wonderful that the CMI and also the ECCMID can offer this platform.
I think it's important
to get this opportunity. Wonderful. And for you personally, this ECCMID, you're also involved in other activities as well, right?
Yes,
I believe you had a Meet the Expert session.
This morning at 7 o'clock.
It was this morning? And it was on the duration of antibiotic treatment.
Yes.
Do you care to share a little bit about your contribution there?
I shared this session. My co-speaker was Jose Pardo, and our assignment was to talk about duration of antibiotic therapy from what we know to what we do. So my task was what we know. So I sort of had to give kind of a laundry list of the data we do have that supports shortening antibiotic therapy, which is what we need to do to decrease emergence of resistance. But I also was able, and then Jose talked about what we actually do, barriers to really using antibiotics wisely and trying to shorten these durations. But in my part, I was able to talk a little bit about not just shortening durations to fixed lengths, but maybe really looking into individualizing durations using biomarker guidance, particularly CRP. We've done some work on that in Geneva and in Switzerland.
Do you believe that the duration of the antibiotic treatment should be individualized, like in
Yes.
each patient?
Yeah, and it's actually possible. We were very happy. We published a study a year and a half ago or so where we compared CRP-guided durations to fixed 14-day durations for gram-negative bloodstream infections. And we also had a third arm where we looked at 7-day fixed durations. And so we compared these new interventions, CRP guidance and fixed 7 days, to this control arm of a longer 14 days, which is quite wasteful, it turns out. You really don't need 14 days. Indeed, we showed that both a 7-day fixed duration and this CRP guidance were non-inferior. Patients do not need 14 days for these gram-negative bloodstream infections. And in our CRP arm, we actually had the fewest failures. We really, it really did the best in terms of clinical failure after stopping antibiotics, relapse. Those patients did very well. And the good news was, when we used CRP, we didn't know in the beginning if we use CRP to stop therapy, will we even spare days of antibiotics? Will we shorten? Actually, there weren't really many trials out there.
But you did know which cutoff value to
We used
choose?
a very simple algorithm. We said, okay, we're going to stop the antibiotic as soon as the CRP falls by 75% of its peak. Yeah, and we had some evidence from the literature for that. We didn't come out of the blue with that. But we found that using that algorithm, we did shorten. It was very antibiotic sparing. The median duration of antibiotic use in that CRP arm was also 7 days. So it was a way of having antibiotic durations from 14 to 7 days, but in a very gentle way for the patient. We really followed the patient's inflammatory response. That's what the CRP is. It's a really sensitive marker of your level of inflammation in response to a bacterial invasion. So we were really pleased about that. And so this morning I was able to kind of go over that literature again. And after re-reviewing the literature, I found that there haven't yet been more trials with CRP guidance. And this is exciting because, oh boy, more work needs to be done, but it's also kind of exhausting because, oh boy, more work needs to be done. Maybe I have to do this. Maybe I have to do a new trial in a different infection. We need more evidence that, not going beyond bloodstream infections, but it should probably be tested in pneumonias and other common infections.
Well, it sounds like you had quite a full ECCMID, but also one with both your roles as a clinician and with your own research line and as an associate editor of the CMI, you managed to fit in both roles, I think, here in your contributions.
I had one other ECCMID activity, if there's time.
Yes, there's definitely time.
I had a wonderful Saturday afternoon. I was, for my first time, I was asked to be part of the Trainee Association event, the TAE Day. And it was so much fun. I was able to sit at a round table.
Was it combined from all the ESCMID study groups, or?
I think so. I think it was just basically the Trainee Association Day.
Trainee Association,
all the young fellows, all the young, the future IDs and clinical microbiologists of Europe and beyond. And it was really fun. We sat at a round table and we each sort of, I think basically they picked like old people, like one old person for a table of young people.
Maybe they just wanted editors.
But it was really fun. I got to talk to them and they were able to, it was, they were asking questions. It's not always easy in Europe and maybe elsewhere too to find a spot in infectious diseases or clinical microbiology, and it's a struggle. And I felt like we really bonded, and we all we had a nice time together.
Well, it's really wonderful to meet new blood, right?
They're amazing. I mean,
did you also get more insights from them or ideas or?
Yeah, definitely. Oh, I mean, mostly I got inspiration. I mean, they're really wonderful, so dedicated to patients and science, and
they don't feel many restrictions.
No,
that's wonderful.
No, they don't, and they better stay that way.
Oh, well, that's excellent. Thank you for sharing that. Well, Thank you also for coming here and just sharing a little bit of your experiences this ECCMID, and also giving us the point of view on why certain research is selected as late breakers. So it was really interesting to hear that from you yourself, coming from the CMI. Thank you for joining us. Thank you for watching us. We will tune out now, but we will be back at the clock of 2 when we will be talking to one of the awardees of the Top Poster Award. So we'll take a little look into her poster and discuss that some more with her. So I hope to see you back at 2 o'clock. See you then.